or emergency medicine, they have to go through, understand how the ultrasonography works, and it works really, really well. Okay. It can help you in your daily routine cases, and it can really make a change in the outcomes of the patient. So probably a few years back, maybe a decade or two back, what stethoscope did is something that ultrasonography is doing now. So it can really be your eyes, ears, where you can use the data available by ultrasonography to the real practical use, where you can use it for quick assessment, repeated assessments, and real-time outcomes assessment. So specifically speaking about neurocritical care today, we all understand that taking patients in neurocritical care to CT scan, repeated CT scans, and cerebral angiography can be really, really troublesome. You cannot do it repeatedly. There is problem with radiation and those kind of things. But use of ultrasonography specifically in some areas can give you a real-time data, repeatable, and it is free of any complications. So I will start with introduction of the faculty and panelists, and then I will hand it over to Dr. Puneet. So this is Easelife Academy, and myself, Dr. Sandeep Agarwal. I will be the moderator today. So I am, as of now, working in Mumbai as head of Department of Critical Care. I am also examiner and teacher of IDCCM and IDCCM. There are two books to my credit, which are MCQs in critical care and clinical cases in critical care. We also have Dr. Florence Almeida, who is working as senior consultant in Fortis Hospital in Delhi. He has over 20 years of experience. He's been a lecturer and author of multiple books and multiple lectures. He will be a panelist today. And another panelist would be Dr. Bhavinish Sabharwal, who is also heading the Department of Critical Care in Mata Chanan Devi Hospital in Delhi. He is also a faculty for DNB training, and he has a vast experience of working in critical care. So you can follow us for Easelife Academy on these given links. Now it is with great pleasure I would like to introduce our primary speaker, who is Dr. Puneet Khanna. Dr. Puneet is Professor of Anesthesiology, Critical Care and Pain Medicine in All India Institute of Medical Sciences, AIIMS, New Delhi. He asked me to, pick up few lines from his huge CV about his achievements. So nothing can justify his achievements. So it is a very short summary. So he is internationally acclaimed because of his pioneering work in intersection of critical care and digital health. He recently is now focusing his research on artificial intelligence and digital health in critical care. He has authored multiple foundational medical textbooks. There are over 300 peer-reviewed scientific documents to his name. He has published more than 30 meta-analysis, more than 34 systemic reviews, and his research impact is H-index is more than 30, and with more than 3,100 citations. So welcome, Dr. Puneet. We also have Dr. Bharat Jigyasi, who is here as expert faculty. Dr. Bharat is, as of now, working as Director in Critical Care Medicine in Kokilaben Dhirubhai Ambani Hospital in Navi Mumbai. He has been a General Secretary of National IACCM. He has chaired the Indian Society of Critical Care Medicine Consensus Statement for Prevention of ET in Critical Care Unit. He has also co-chaired IACCM guidelines for use of non-invasive ventilation in acute respiratory failure. He has been awarded as Mumbai's youngest talent twice. He has received IACCM President Citation for consecutive last 5 years. Also featured twice as Mumbai's top doctors. So welcome, Dr. Bharat Jigyasi. And I am...
Thank you, Dr. Sandeep. Thanks.
I am handing over to Dr. Puneet, and I'm very, very sure that we are going to have a very well learning session today. Over to you, Dr. Puneet.
Thank you. And
Before we start, I think just a second. I hope the screen is audible. Screen is
Visible.
visible. I
Yes,
am
sir.
audible
Visible.
to everyone.
Yes,
Fine.
sir. Yes. Yes.
ठीक है. So we'll keep it short and sweet. Uh, Thank you for the introduction and thank you for giving me the opportunity. The topic is a little tricky because I work in a general ICU, not in a neurocritical care ICU, but now it has become the part and parcel. We have a TCD probe, and it is quite often we use it now. And we started with ultrasound teaching somewhere way back, some 12 years back, and I had a textbook on ultrasound in critical care somewhere in 1718. The Usually we used to deal with all the topics with very fluently. Ultrasound in neurocritical care was like not every ICU used to have a TCD probe, specifically neurocritical care ICUs have, but now general ICUs also have a TCD probe. Even if when we didn't have a TCD probe, we used to do it with a echo probe. So we will stick to the basics and try to gather what maximum in a minimum amount of time. Fine.
Right.
So ultrasound in neurocritical care, basics, everybody knows what is a.
Dr. Puneet, what I can see is your slide window is small and your
Okay, now it is okay.
no, again, it is in the smaller window. The
Okay.
slides are in smaller window. I think you will need to switch to it.
मैंने I think कर दिया था इसको. No, isn't it a full screen?
No, at least I cannot see it in full screen.
I am seeing it in full screen, so I can try it again if you want.
I can see you in full screen, but not
Eh?
the slides. I can see you
I
in
have
full
I
screen.
have hidden myself totally.
Yes, sir. It is full screen. We can. I can see it.
Okay, then go ahead.
Okay,
Maybe I can.
I have hidden myself and it is totally full screen. Okay.
ठीक है.
Okay,
Okay,
sir. Please.
Okay.
Okay.
go ahead.
So let's stick to the basics. Very clear: ultrasound, sound waves beyond the audible range, transducers, piezoelectric crystals. Now, what has changed in ultrasound transducers? Previously, we used to have 3, 4 different probes. Fine. In the say like a linear probe, low frequency probe, echo probe, curvilinear probe. Nowadays, what advancements has taken place? Piezoelectric used to be a collection of crystals. Now, new technology, you have a single crystal probes, and a single probe can change its configuration to a linear, to a curvilinear, to a echo probe. So this is the things which is coming in the present day scenario. Simple principle: impulse is generated, crystals vibrate, ultrasound waves are generated, it comes across a tissue, returns as an echo, crystal deformation takes place, electrical signals are converted to image formation. So what has changed in the previous days probes and these days probes? There is no need to have different probes. Instead of many piezoelectric crystals, you have a single crystal which keeps on changing the shape. Cycling between transmission and reception 1000 times per second to produce a real-time image. High frequency, better resolution, lesser depth, and a lower frequency, vice versa. Just give me a sec. I'm finding a little difficulty in changing of the slides. Give me a minute. Yeah, is it okay now?
Yes, yes.
Yeah. So basic principle again remains the same: air, fat, fluid, blood, liver, kidney, muscle, bone. Hypoechoic, fluid, hypoechoic, blood, very hypoechoic, bone, hyperechoic. These are very basic principles. Now let us go to the neuropocus. The pocus in neurocritical care, limited examinations, critical for sedated and comatose patient, real-time physiology, instant bedside cerebral insights, safety first, avoids risky transport to the radiology suite, patient-centric, non-invasive, repetitive, radiation-free, dynamic detection, monitors changes in the ICP, perfusion, complementary. It enhances the standard CT MRI diagnostics. And the most important is it is very rapid, immediate clinical decision making. So from anatomy to the physiology at bedside is what neuro-focus matters. Applications, cerebral hemodynamics, you can measure the flow velocity, look out for autoregulation, vasospasm, stenosis, and you can assess if there is an ongoing stroke. ICP and structural changes, you can detect raised ICP, midline shifts, and monitor serially optic nerve sheath diameters, which is an indirect reflector of a raised intracranial pressure. Neuromonitoring, identifying brain death patients, facilitating serial monitoring in TBI, and an integrated approach combining with cardiac, lung, and vascular ultrasound for comprehensive care. See, let it be any ICU, ultrasound has become the part of the normal routine. So as we take a round, move from one bed to the other, the ultrasound is an integral part of it. Stethoscope was an integral part of it. Now, ultrasound is an integral part of it. Head to toe examination can be carried out by an ultrasound probe. Just to cite out, this is neurofocus. The things have highlighted to such a stage, even a rheumatologist, by looking at the crystals in your great toe, can tell you whether it is a urate crystal or something else. So that is the advancement that has taken place in ultrasound in critical care. So let us start with the basics. TCD, transcranial Doppler. It is a non-invasive bedside tool for monitoring cerebral hemodynamics. First described in basal cerebral artery in 1982. And further innovations have been taking place. Power motion mode, Doppler mode by Mark in 2002, and it is still ongoing. The probe has become smaller, the area and the visualization fields have increased. Physics, window. The thin portion of the skull acts as a acoustic window. Target are the intracranial arteries. Probe is a low frequency probe with a circular footprint. And physics is a Doppler frequency shift. TCD probe emits a sound wave. The ultrasonic beam crosses the intact skull. It is reflected back from the RBC or other thyrocytes, and it is captured back by the probe. The difference in the frequency between the transmitted and the received signal is received as a Doppler shift. This is the basic principle. Mainly we use 4 windows: transtemporal, submandibular, transorbital, and suboccipital. A, B, C, D, you can say transtemporal, submandibular, transorbital, and suboccipital. And this most commonly are used in this order only. This is a little much more theoretical. The identification depends upon the window of insertion, depth of the sample volume, direction of the probe, and overall visualization of the waveform pattern. So it's like different areas: basilar artery, middle cerebral artery, ICA bifurcation, PCA, ACA. So let's concentrate what will be the direction of a flow. This can always be checked upon. There is no need to cram it up. And what are the relative mean flow velocities that has been mentioned in this flow chart. How to analyze the TCD waveform? The transcranial Doppler uses spectral analysis. It presents a 3-dimensional Doppler data into a 2-dimensional format. So a normal spectral waveform shows a sharp systolic upstroke, then a deceleration, and then a positive and diastolic disflow. So if you have to describe peak systolic velocity, which is the first peak on a TCD waveform from each cardiac cycle, a rapid upstroke. What does a rapid upstroke tell us? Any absence. There is an absence of any stenotic lesion जहां पे आपने probe रखा था, insonated intracranial arterial segment and the heart. So there is no stenotic lesion over there. So you can see time is on the horizontal scale, frequency shift velocity is on the vertical scale, and a single intensity is represented as a relative brightness of the color. Time, velocity, systolic peaks, and the diastolic peak. Frequency shift on a vertical scale. So let's go further. And diastolic velocity. And diastolic velocity lies between 20 to 50% of the peak systolic velocity, indicating a low resistance and in the intracranial arterial flow pattern. Going further, mean is like same and diastolic plus 1 upon 1/3 of the systolic minus diastolic. The values for the mean MCA flow in the healthy adult ranges from 35 to 90 centimeters under the normal physiological condition. It has the least variation and therefore hence is most useful for interpretation. Middle cerebral artery. So this is the normal transcranial Doppler using a temporal acoustic window which shows M1, M2, MCA, ipsilateral ACA, contralateral. These are the various normal physiological which are shown in a TCD. A, B, C and D. A is MCA, B is ACA, C is again A1 ACA and D is the bottom frame, showing the Doppler spectrum from the M1 MCA. So what are we actually gaining by systolic velocity, diastolic velocity or the mean velocity? We try to find out the pulsatility index. It is the most frequently used TCD parameter to determine the flow resistance. Pulsatility index is defined as like a peak systolic minus diastolic upon the mean. Normal range is 0.6 to 1.1. If a value of more than 1.2 comes, it represents a resistance to the blood flow. Increased downstream resistance depicts vasospasm or ICP, which causes the PI to rise above 1.19 or 1.2. In cases of venous malformation or arteries acting as feeders, PI is reduced. So what to catch from this slide or take home from this slide is normal range of a pulsatility index is 0.6 to 1.1. Anything above 1.2 shows a resistance. Increased downstream resistance occur in vasospasm or in ICP. Resistance index, it assesses the flow resistance. Again, it's a simple principle, resistive index, systolic minus diastolic upon peak systolic. And resistive index less than 0.75 is considered normal. As the resistance increases, the flow of blood during the diastole decreases and the end diastolic volume drops to 0. The closer the Ri is to 1, the greater is the resistance to the flow. So pulsatility index, resistive index increases as the resistance increases. These are the physiological determinants, factors which affect mean flow are like age, sex, pregnancy, PCO2, mean arterial pressure, and hematocrit. Age increases up to 6 to 10 years of age and then it decreases higher in women than men. Pregnancy during third trimester. It increases with PCO2. It increases with increasing MAP, cerebral blood flow, auto-regulates between cerebral blood perfusion pressure between 50 to 150 and it increases with decreasing the hematocrit. Clinical uses, vasospasm after hemorrhage, raised ICP, you can detect for a head injury, cerebral circulatory arrest and auto-regulation testing. Other uses may be in ischemic cerebrovascular disease, carotid endarterectomies and pharmacological vasomonitor testings. Grading of vasospasm after subarachnoid hemorrhage. Vasospasm typically develops between 4 to say like 17 aneurysmal subarachnoid hemorrhage. It can be classified by peak systolic flow, mean and Lingard ratio, mild, moderate and severe. Let's consider it as mild is 200 to 250 centimeter per second, moderate is 250 to 300 and severe is greater than 300. Lingard ratio, it helps in differentiation of a hyperdynamic flow and a vasospasm. So, MCA, mean flow and the extracranial ICA flow, it's the ratio of to that. If a Lingard ratio is less than 3, it's a hyperdynamic flow. If it is greater than 3, it is a vasospasm. So basically, you are looking at MCA and ICA, mean flows, pathological patterns, global hypoperfusions, mean values below the reference range, that is less than 30, low velocities with a relative normal PI, low velocities with a markedly elevated PI. If it is a normal PI, low velocity, there can be an infarction or an encephalopathy. Low velocity with an elevated PI might suggest a critically reduced CPP from hypotension. Trend analysis and integration with clinical status are the essence and are essential to interpret hypoperfusion patterns. So, see, doing an ultrasound, doing a transcranial Doppler, or doing a echo, it has got inter-observer variability. So I do it, you do it, there can be a difference in it. And the best part of having an ultrasound or a TCD or an echo probe is that you can always do it serially and correlate it clinically. Minimum radiation exposure, it's a bedside tool. So trend, basically what I'm trying to convey through this is trend analysis is always better than an absolute value. If you have a particular trend, that is much more significant rather than having an particular absolute value of a particular thing. Pathological patterns in hyperemia, it shows global elevated systolic volume, diastolic volume with preserved or accentuated low resistance pattern. Common causes include sepsis, hypercapnia, fever. You can differentiate it from focal vasospasm, relying upon the symmetry. Systemic parameters such as heart rate, blood pressure, hemoglobin should also be reviewed. See, we had seen hematocrit influences it. Partial pressure of carbon dioxide or mean CO2 also influences it. TCD, in case of raised intracranial pressure, it's a downstream resistance, reduces the diastolic velocities and raises the PI. Traumatic brain injuries highlights PI greater than 1.3, very little diastolic flow will be there. As ICP approaches, the mean arterial flow diastolic falls to 0 and may reverse. It may produce oscillating flow patterns. So again, I will hamper upon the fact sequential TCD allows bedside detection of the worsening of ICP and assessment of response to the therapy. This is a little new thing, like transcranial color Doppler screenings. TCCS can visualize parenchyma and extraaxial hematomas based upon echogenicity and location. Obviously, this all comes with practice, and we are still in that mode of practicing it out. Acute hematomas usually appear hyperechoic relative to the brain parenchyma. Subacute collections becomes much more hypoechoic with the hyperechoic rim as they evolve. Bedside volume estimation can be followed by a simple formula, height into anterior posterior into transverse upon 2. So acute hematomas hyperechoic relative to the brain parenchyma. Subacute collections becomes much more hypoechoic with a hyperechoic rim as they evolve. Bedside estimation using a simple formula. This is a pictorial representation how calipers can be used to detect left interparenchymal hematoma, mesenchymal hematoma in a B figure, right intracranial hematoma, and D as an extra axial hematoma. Midline shift. This is important to us. Midline shift is assessed by in a diencephalic plane using the third ventricle as a surrogate midline. हम ये मान के चलते हैं, we consider that a third ventricle is considered as a surrogate midline. Depth from the probe to the third ventricle is measured and it is calculated as A to B upon 2. We take 2 points. Depth from the probe to the third ventricle is measured and it is divided by 2. Values greater than 2.5 correspond clinically as a clinical shift. Fine. This is how you see. In this, it is negligible. We take it as a distance. Fine. And then distance between those 2 points and then divide by 2. We measure it in the diencephalic plane using the third ventricle as a surrogate marker of the midline. Depth is measured from each side and then it is calculated A minus B upon 2. Fine. Hydrocephalus, this is much more easily measured in pediatric age groups. Even it can be measured again in the adults. You have to consider again the diencephalic plane. And typically, young adults have a third ventricle diameters around 5 millimeter, and older adults often have large reference value. Progressive enlargement suggests worsening of hydrocephalus. Again, monitoring the trend is much more important rather than a single absolute value. Repeated measurements can support the decision whether an EVD has to be played for CSF diversion or not. Brain death when ICP exceeds the arterial pressure, intracranial circulatory arrest pattern occurs. So there are oscillating flow equals systolic and reverse diastolic components with a zero net flow. Systolic spikes are very short, low amplitude with absence diastolic flow. Obviously, you cannot make a pinpoint diagnosis with this. You have to use brain death confirmation protocols which require these typical waveforms in multiple arteries and at least in 2 occasions at 2 separate times. And rest of the policies are according to the local ICU policies which you follow. Again, this has to be clinically confirmed, but this flow and spikes have to be confirmed at least 2 examinations in separate time frames. This is for completion's sake. Sickle cell disease, there is increased level of sickle cells which increases the adherence to the vascular endothelium, causes occlusion and may result in stenosis or stroke. TCT can be used for screening cerebral blood flow and guiding the treatment. Mean flow of more than 200 centimeter per second may have a statistically significant increased risk of stroke. Narrower the area, more is the flow and more is the risk. Ischemic stroke, TCT establishes location of intraarterial occlusion, has a relative good sensitivity and a positive and negative predictive value, 96, 75, 96 and 75. It helps in evaluating hemodynamic consequences of an arterial occlusion, and it also plays a real-time monitoring of, you can see how the recanalization and the change in velocities is occurring while thrombolysis. So diagnostic criteria during stenosis, MCA, ACA, PCA 140, 120 and 90. Again, we'll come on to a relatively very easier topic now, which everybody of us do it, like optic nerve sheath diameter. So basically you have to put a tape around the eye, put a jelly and then put a probe, linear probe having a frequency 5 to 10 millihertz is used to perform. Depth is adjusted up to 5 to 6 centimeter. Patient is placed and examined in the supine position. Patients can be, even in a cooperative patient, you can tell him to maintain a midline, which is difficult in our ICU patients, and apply the gel, close the lid and place the transducer softly. We cannot apply too much pressure. Increase in the intracranial pressure can lead to its own consequences. So ONSD measured by a linear frequency probe placed over the closed eyelid with a gel. It is measured 3 millimeter behind the retina. 3 millimeter behind the retina and inner border to the perpendicular to the nerve. Adult threshold is around 5 to 6 millimeter and commonly used values are more than 6 millimeter suggest a raised ICP. Again, this is relative. You do it, I do it. We might have some difference in it. So again, it is better we measure a trend. Pupillary ultrasound in neurocritical care, assessment of the iris and pupil when eyelids are swollen, ocular trauma precludes the direct inspection. People can, dynamic recording of the pupil size can be recorded, and in suspected carotid dissections or patterns, Horner syndromes, patterns of preserved light reflex, they are quite notable. Orbital ultrasound may again follow strict principles to protect the eye. Contraindications are trauma, neuritis, atrophy, hematoma, glaucoma, hyperthyroidism, and exophthalmos. What's the conclusion? Basically, it provides radiation-free bedside physiological information. Important point here to highlight it, it complements the CT and MRI. It's not the substitute for CT and MRI. If you integrate a brain focus with a systemic stroke focus, it improves early detection and detection of complications as well. Everything has its own competency-based training protocols, and you have to learn it slowly and slowly. Nowadays, as I earlier pointed out, a single crystal has come. Artificial intelligence has also come. Tools have become handheld devices, but having a handheld ultrasound in India is a little difficult according to the laws for detection of sex. So we won't, it's highly unlikely that we will have handheld devices. Maybe possible uh, in a hospital setup, but it's quite unlikely. And the brain focus is likely to pick up in the coming years. It's not necessary that it has to be a part of a neurocritical care. It has become essential part of a general critical care as well. We are seeing patients very commonly with AMS, altered mental status, and strokes, and various other things, raised intracranial pressures or herniations. These can be monitored, and a trend can be assessed over a period of time. So limitations are again operator dependent. You do it, I do it, there will be a difference. Up to 20%, it is at times difficult to find an adequate temporal window. Hyperdynamic circulations, anemia, hypercapnia can mimic vasospasm by raising the mean flows or focal narrowing. Incorrect vessel identification, poor angle may produce misleading velocities. Finding must always be integrated with this thing, CT and MRI for neuromonitoring in a clinical context. Thank you.
Thank you so much, Dr. Puneet, for.
I am really sorry I had to hush it through, but I wanted to keep it as small as possible.
Yes, I think that is the right way to go. And we will complement this talk with questions from the panelists and from the.
Yeah, please, it should be a healthy discussion. I myself admitted it. It's not necessary that we are. See, I'll tell you very frankly what we have been using it for. ONSD is very commonly used. Any comatose patient, an indirect reflection for this thing, intracranial pressure. Any altered mental status, we document it on the chart every day. What has been the trend of ONSD? Yes, TCD probes are very common in neurocritical care. General ICUs having a TCD probe is relatively new.
So I think in current scenario, I feel that using ONSD is definitely very easy. I think it has very short learning curve, and people can start using it very often. Second important thing is probably TCD use, specifically in patients with the aneurysmal SAH to measure the velocities, which can give you a definite insight. And I think there is some learning curve, but I don't think that there is a huge learning curve. The learning curve is steep.
Yeah. It's like the present day machines are so good that these things can be easily taken care of.
Still, I feel that the use of ultrasonography being so helpful in so many patients in so many things, it is still underutilized. First part is probably because of lack of awareness, lack of availability, and third part is probably something new takes time to percolate down.
Definitely.
And that was the my idea to have a series of webinar on use of ultrasonography, so that all of us can learn a little bit more and be more confident about using it.
Yeah, definitely.
TCD is. Yes.
I like to highlight one thing. See, ONSD has become a part of our daily routine.
Correct.
Fine. And yes, that you measure an ONSD and I measure an ONSD, it will be a little different, to be very frank.
Right.
So a trend analysis always help. Now this is just off the record. It's not necessary that TCT probe might be present everywhere. So what we try to do is we use the simple echo probe only. कितने साल तक हमने वही किया.
वही यूज कर
वो
रहे हैं,
टेम्पोरल
exactly.
विंडो पे मिडिल सेरिब्रल आर्टरी का फ्लो डिटेक्शन देख लेते थे. We even if we don't have this thing absolute values, you can get a trend out of it.
Agreed. And it works best when the patient has decompressive hemicranectomy.
Yeah.
Then you can see all the things
Directly you
shown.
can see it.
You can
Yes.
see the ventricle. Anybody can see it. It becomes so easy
Yes.
to monitor such kind of patients. Even the interventricular tip of the catheter, drainage catheter, can also be seen. So I think it is not a substitute for the advanced monitoring or the imaging, but yes, it can be really helpful if used in the particular patient population and particular environment.
Sandeep, I think I was going through some questions in that chat box.
Yes, sir. There are a lot of questions.
Yeah, see, it is very difficult to demonstrate anything over here.
It
So
is.
very soon we are having, sir, hands-on session, and
but
definitely we will show each and everything at that time.
It's possible only to record a video and then tell it one thing. Or when you will finish through this theoretical webinars, you can have a practical workshop.
Definitely, sir. Very soon we are going to
Yes.
organize this thing. But a little question from my side, sir. First of all, thank you for enlightening this complicated issue in a very, very concise manner. So I just want to know that how reliable is the Lindegrad ratio in differentiating vasospasm versus hyperemia in your daily practice, sir?
सर देखो सेंसिटिविटी तो बहुत अच्छी है बट स्पेसिफिसिटी नहीं है टू बी वेरी फ्रैंक. मतलब आई कैन नॉट बी 100% स्पेसिफिक. सेंसिटिविटी में पिकअप कर सकता हूँ वैसोस्पाज्म हो रहा है अप टू 90 to 95%. बट इफ यू वांट टू बी वेरी स्पेसिफिक वो ना नीचे आ जाता है 60-70% के आसपास.
बट एनीवेज मतलब क्लिनिकली कुछ हेल्प मिल सकता है.
हाँ डेफिनेटली इफ यू कोरिलेट इट विद द कंडीशंस लाइंग वेन डेफिनेटली हेल्प मिलता है.
Thank you, sir. Dr. Florence, anything you want to add?
Hi, Dr. Puneet. I just had some couple of basic questions.
हाँ सर.
What do you think would be the basic mistakes which beginners make while doing this? Because lot of young population is out here. What do you think are the basic errors?
Sir, basic thing is to location of the probe and identification of the structures.
Okay, so that's the first thing.
सबसे ज्यादा गलती वही होती है क्योंकि this is not an area which we do it very often.
Okay.
Yes,
Right? Heart chambers are very easy to identify. But once we start doing it, it will have its own time period. Yes, but the numbers, one thing good with TCT is if you have placed the correct anatomical point, you have placed the probe, at least the numbers will tell you the right thing.
Okay. So the first challenge is to identify the structures.
Identify the structures.
And how's the learning curve for this?
Sir, most of the machines these days are so much packed, I'll tell you they will tell you in a form like green, yellow or red. Supposingly you choose a particular area, you are going at the middle cerebral artery or a temporal window. The machines have improved to such an extent that you take a reading, they will tell you it is red, that you have placed it wrong. If it is yellow, they'll say you are okay. If they give you a green signal, you can just go ahead and take the reading. But they have improved to such an extent these days.
Okay, perfect. Okay, so another thing is there any possibility that invasive ICP monitoring can be replaced over a period of time using this?
No, I don't think so, sir. It's just for monitoring the trends. You cannot replace a CT, you cannot replace an MR, neither can you replace a invasive ICP. Definitely in cases which is required. But yeah, general ICUs, it is such a quick thing. Now you do an ONSD, you do this thing, that's it. You measure the trend, you keep on changing the shifts. Like after every 6 hours you do it, you can tell it very easily how fast it is going. But obviously this thing cannot be absolute. You have to corroborate it with, again, clinically your CO2 is building up. Then your PCO2 will rise and your ICP will again rise. So you have to correlate it clinically, just not depend directly upon the waveforms like that.
What about using as a screening tool if the patient has symptoms of vasospasm Can you use it as a screening tool?
Yeah, definitely you can use it as a screening tool. Definitely you can use it as a screening.
Thank you so much. It was a very nice, precise, and concise lecture.
Yeah, see,
Pleasure
there
to have
is
you here.
attention span does not goes beyond 20 minutes. So I thought how to compress it
Can I
as
now
quick as possible.
can I now also bring Dr. Bharat Jagiasi? So Bharat, how often do you use ONSD?
So first of all, Sandeep, thank you for doing this. I mean, it's an amazing thing. We are doing it a free webinar for people. And Dr. Puneet's talk was really enlightening. And as he said, he uses it very often. So I would put it across into two things. One is when we think of using ONSD in diagnosing what is happening, I think he's very clear in that. And he said there we cannot use it. So very small amount of subset of patient where I don't routinely use in those set of the patient is severe TBI when there's an unexplained deterioration, when there's and I cannot move the patient. Suspected raised ICP with examination clinical is difficult because the patient is sedated and paralyzed, or maybe when there's a hepatic answer with a cerebral edema. But when I know really there's a problem, there's a raised ICP, and now I need to monitor the trend, whether it's worsening, whether my treatment is effective or not. I give either hypertonic saline, I give mannitol, or maybe the PCO2 going up, as he said. There is very useful to monitor the trends of it. So there are two broad spectrum where we have to use it. When it comes to the looking at the trend, effectiveness of your treatment, whether the patient is worsening or is getting better, is really a good tool to have it. And again, you need to monitor it well. When you have to diagnose it, what is happening around, I wouldn't prefer it using it upfrontly unless and until there are certain different issues where I cannot move my patients or I cannot do scans again and again, or as I said, hepatic encephalopathy, I don't expect something just a cerebral edema.
So probably if you are in a dilemma, you will go for a neuroimaging, proper neuroimaging, and not use ONSD if they are showing.
Yeah, for the diagnosis, not. Yeah. Once I confirmed it's a raised ICP is an issue, to look the effectiveness of my treatment, I'll use it. Yeah.
As Dr. Puneet said, trend is
It's
the
a trend tool. Yeah.
Trend is better.
It's a trend tool.
Most important thing to see. If your maybe ONSD was high, you have started hyperosmolar therapy or something else, and now the ONSD has reduced, probably that is the right trend.
Yes. So because it's difficult and you don't know how the pupils are going to be, because the pupillary reaction is going to come late. I mean, when you pick up a pupillary dilatation, damage has already happened. So this is very good tool somewhere in between where you pick up a pupillary dilatation where the raised ICP has come in. Here you can intervene faster.
Correct. And also, I think TCD has been used now more frequently and more increasingly for even for the determination of additional tests for brain death.
No. TCD as an additional test for the brain death. I mean, we just to let you know, I'm part of the guidelines which have been made by the NOTO, and I was heading the section along with Dr. Srinivas Samavidam. I was looking into the sections of ancillary test. So there we had a great discussion about the TCD, and eventually we pulled it out with the discussion of the experts, because the reason being is, it's operator dependent. You can prove it both the ways. So it gets really difficult to have TCD over there because interpretation is very not right. And so as an ancillary tool to diagnose brain death is no.
Bharat, it is quite possible that it's not present everywhere. Every ICU might not have it also, na?
Yeah, so this is about the ancillary test. So when you have it, you do it. Otherwise, you don't do it. But even in that situation, we pulled it off because it's operator dependent, and brain death is a very sensitive issue. Anyways, you can prove it if you want to prove it. Patient is brain dead. Yeah.
Correct, and it is very, very important.
Yeah.
Important decision to take. Okay. Do we have any other questions? Any major questions?
From the chat box, you can take, Dr. Sandeep, if there is any question.
Right. Let me see. Just give me a minute.
So someone asked, portable MRI can be the future, although neurofocus will remain very cost effective.
Another thing is, any tips and tricks to optimize image when window is poor, especially in elderly obese individuals.
It's difficult for him and it's difficult for all of us.
All of us.
It's all practice.
With practice, we can do. We don't require neurophysician to involve to diagnose these things and to
It has to be done, I think.
Bhavinish and Sandeep, I would like to just emphasize upon the fact we should incorporate it into a routine practice
Hmm.
and measure the trends, and not for diagnosis. And see, what all we forget now, I always used to say that we are not replacing a radiologist.
Yes.
Okay, we are doing a point of care assessment and doing an intervention according to that.
Hmm.
So we are not here to replace a cardiologist. We are not here to replace a neurologist or a radiologist. But at that point of time, when we have to take a decision and we don't have people to back us up, this will help us out.
Agreed.
So this is a better monitoring tool, as I spoke about the pupillary dilation, somewhere in between, because there, if we pick it up, yeah, it's fixed, it's quite late. So if we do routine, these things will pick up earlier than the damage has actually occurred.
True.
And same is for the, when we spoke about the vasospasm and the TCD, so the clinical relevance will come only when the vasospasm has happened. I will see their hand is weak, leg is weak. But when you look at the flow, when you see increase in the velocity, you will pick up vasospasm much before it has happened, and you will intervene before the damage has happened. So this is why it's been said, especially in those days when the risk of the vasospasm is quite high, day 2 to 5, 5 to 7. If you do routine TCD, you will pick up vasospasm before it has actually happened. So it's more of a monitoring tool than a diagnostic tool. And this is where Dr. Puneet rightly put it across. I'm not replacing a neurophysician, so they don't come for the monitoring. We are not replacing a cardiologist. They don't come for monitoring is our forte. So this is a monitoring tool for us.
One very interesting question. I think all of us can contribute to it. Just have a look. I found it really interesting. Somebody asked, like, ONSD can be a surrogate to an obstetric patient awaiting lumbar puncture. So basically what we are worried about is like fundoscopy, what we see is raised intracranial pressure. And I don't think so. A raised intracranial pressure is an absolute contraindication at that point of time when you have to make a diagnosis. Your thoughts about it? Fundoscopy cannot be replaced as far as I know. It's very difficult.
I agree. I think again it can be an additional tool. Again, then same things.
What point Dr. Puneet was making is basically he was saying if there's a papillary edema and if I need to diagnose something, would you not do the lumbar puncture? This is what he's saying. So this probability of coming in raised ICP, papillary edema, being a contraindication for lumbar puncture was old days, and we're using the bigger needles, 20 gauge needles, 18 gauge needles. Nowadays, what we do is 24, 26, so a very controlled flow. So what he meant is, even if there's a papillary edema, should we not be doing lumbar puncture? That's what he's asking.
Yeah. So basically, see, what are you trying to pick up on a fundoscopy is this only.
Yeah. So eventually, I think if you need to diagnose, you should go ahead with the guarded and
guarded.
You have such 27 gauge needles these days. Control flow, yeah.
So we can go for lumbar puncture. So probably she got her answer, Dr. Saab, probably. And still evolving era, we should keep the data and come up with our own numbers based on the data. Yeah, definitely we need some studies to get some data here. Anybody else want to ask anything? Or if you are having any questions, you can get the link of Easelife Healthcare Academy. You can post your questions there, and you are most welcome. We are very much interested to answer your questions. Or very soon we are going to organize one hands-on session. Everybody will get that message very soon. And Dr. Puneet, definitely he will also join us. So very soon we are going to declare that date. So Dr. Sandeep, anything else you want to add?
No, I think we have had a good discussion.
So
request everybody to take a leave.
Thank you, sir. Thank you, Dr. Puneet. Thank you, Bharat
Thank
sir.
you, everyone. Thank you, Bharat. Thank you, Sandeep.
Thank you.
Thank you.
Thank you, sir.
And stay tuned for the next session. We will be announcing soon. So that will be on critical care echocardiography.
Okay.
Right.
Good night.
Bye-bye.
Thank you.
Okay. Good night.
Good night.